Bismillahirrahmanirrahim. I am Dr. Osama Shafie. We'll talk today about a rapid revision on the neurophysiology. Our agenda today, we will talk about the action potential and the impulse propagation, neurotransmitters, rapid review about the motor system, cerebellum, and the basal ganglia. The action potential or impulse propagation. How the action potential is initiated or the impulse through the neurons or through the nervous system is generated. At first, we need a stimulus, and this stimulus needs to reach certain intensity to cause stimulation or to start the wave of depolarization. So it has to change the membrane potential from the resting point, which is -70, to -55, which is the firing threshold, and then the depolarization phase will start. After the depolarization reaches its maximum, the repolarizing phase starts to reach the after hyperpolarization phase, and the neuron become in a refractory period. The start of the impulse is at the junction of the axon hillock and the initial segment, and then propagated through the axon to the axon terminal. For propagation or conduction of the action potential after initiation of the impulse at the trigger zone here depends on the type of the axons, which may be unmyelinated or myelinated. In the unmyelinated fibers, we have a continuous pattern of conduction. This is the site of the trigger zone, the first stimulus, which causes opening of the sodium channel and the starting of the action potential, then propagated to the next zone, and the same process occur again, then to the next zone, again and again and again, to reaching the end of the axon. While in the myelinated fibers, the process occurs at the paired area, but the myelinated areas conduct the action potential. Okay, so starting here at the trigger zone, then along the myelinated bar, the impulse is transmitted to the next node of Ranvier, and the process occur again, then transmitted through the myelinated fiber to the next node of Ranvier. So if you look here, after 10 milliseconds from the stimulus, the propagation of the action potential reached here in the unmyelinated fibers, while in the myelinated fiber is nearly at the end of the axon. So the myelin maintain fast conduction of action potential, which is called the saltatory conduction. And any lesion affecting the myelin here will cause slow conduction of the action potential. So again, myelin subserve saltatory conduction of the impulse in the healthy nervous system. But we have an important example for diseases affecting the myelin, which is called the MS or multiple sclerosis. This is the normal nerve. We have intact myelin, node of Ranvier, and intact myelin. In the multiple sclerosis, we have antibody or autoimmune process attacking the myelin, causing its destruction and bearing or exposing of the axon, causing impairment of the conduction of the action potential. The neurotransmitters. The neurotransmitters are chemical substances that are formed within the neurons. They are stored in vesicles and then released by exocytosis, then bind to the postsynaptic receptors and start their action. After they are binding to the receptors, the rest of the neurotransmitters are inactivated by either reuptake or by degradation by several enzymes responsible for neurotransmitters degradation. The response to the neurotransmitters depends on the type of the receptor the neurotransmitter bind to, either ion channel or G protein coupled receptor, and the response may be excitatory by stimulation of the sodium channels to be opened, inhibition of conduction through chloride or potassium channels, changes in the intracellular metabolism causing either increase or decrease of expression of certain receptors. The inhibitory response to the neurotransmitters is caused by opening of chloride channels, increase in the conduction through the potassium channels, changes in the intracellular metabolism. Excitatory neurotransmitters include acetylcholine, dopamine, norepinephrine, epinephrine, serotonin, and the inhibitory includes GABA and glycine. As regards the acetylcholine, which is the most abundant neurotransmitter in the nervous system, it is found in the large pyramidal cells from the motor cortex in the basal ganglia, somatic neurons, all preganglionic autonomic neurons, parasympathetic postganglionic neurons. Its action is excitatory in the CNS, and in the peripheral nervous system it has mixed action depending on the type of the receptor, either nicotinic or muscarinic receptor. It is sensitized in the terminals of the neurons from the acetyl coenzyme A and choline by choline acetyltransferase enzyme. Then it is stored in the vesicles in the nerve terminal. The acetylcholine is stored in the vesicles in the nerve terminal and is released by exocytosis, then bind to the postsynaptic receptors on the skeletal muscle fiber membrane, which are the nicotinic receptors, causing membrane depolarization, action potential starting, and muscle contraction. But if the acetylcholine bind to postsynaptic muscarinic receptors, which are found in the smooth muscles and the cardiac muscles, it causes hyperpolarization and muscle relaxation. After the acetylcholine performs its action, the excess acetylcholine will be degraded by the acetylcholinesterase enzyme into choline, and the choline is restored to the nerve terminal by sodium driving cotransport. Another important neurotransmitter is the dopamine. Dopamine, which is the neurotransmitter for neurons with cell bodies in the midbrain and the axons projecting either into the nigrostriatal pathway or the mesolimbic pathway. The nigrostriatal pathway starts in the substantia nigra and goes to the corpus striatum part of the basal ganglia and share in the initiation of skeletal muscle movement. The pathology in this pathway causing the disease called Parkinson's disease. The mesolimbic pathway starting from the midbrain to the limbic system, and it is involved in the behavior and reward mechanism. Another important neurotransmitter, which is the dopamine, which is sensitized from the tyrosine using tyrosine hydroxylase to be converted to DOPA and by DOPA decarboxylase to dopamine. The L-DOPA can cross the blood-brain barrier while the dopamine cannot, as it is converted peripherally into dopamine by DOPA decarboxylase enzyme. So we use carbidopa to block the peripheral conversion of L-DOPA to dopamine when using dopamine as a treatment. When using L-DOPA as a treatment in Parkinson's disease, we combine the L-DOPA with carbidopa to prevent the peripheral conversion of L-dopa to dopamine. After performing its action, the reuptake of dopamine is done by the dopamine transporter, and the degradation is by the MAO and COMT enzymes. Um, and the end metabolite is the homovanillic acid, which is a marker for the activity of the dopamine system within the brain. The motor system review. We'll remember some items about the motor system physiology, including the motor tone or the muscle tone. The muscle tone is a state of mild maintained contraction or a state of partial contraction in the skeletal muscle when during rest. So it is a partial contraction of the muscle during rest. It is the static type of the stretch reflex. The cause or the etiology of the muscle tone is that the skeletal muscles during rest are slightly stretched, as they are slightly shorter than the distance between the origin and the insertion of the muscle, so the muscles are in a state of continuous slight stretch, causing stimulation of the muscle spindle and cause mild partial maintained contraction, which is called the muscle tone. Normally, muscle tone is present in all muscles, but it is more marked in the anti-gravity muscles to maintain our posture. The function of the muscle tone is to maintain our posture and to maintain our equilibrium and maintaining our normal body temperature, as it is a major source of heat production, helping the venous return and lymph drainage, helping to keep the viscera in position by the muscle tone of the abdominal muscles. It is important in the neurological examination to identify the muscle tone, if is it normal or abnormal, and depending on the result of the examination we can identify the site of the lesion. So the muscle tone may be hypertonia, increased muscle tone, which is either rigidity or spasticity, and it is associated with upper motor neuron lesion. Hypotonia or atonia can be caused by a lower motor neuron lesion and the acute stage of the upper motor neuron lesion. Another type of the stretch reflex is the dynamic stretch reflex or the tendon jerk. The tendon jerk is done by tapping, sudden tap on the tendon, causing sudden stretch of the muscle fibers, causing stimulation of the dynamic nuclear bag fibers, and the afferent impulses arise through the dorsal root ganglion to the anterior horn cells, and then the efferent fibers send impulse to the stretched muscle, causing sudden contraction and jerky movement of the limb. The variation in the result of tendon jerk examination may be increased hyperreflexia, in the hypertonia, in tetany, anxiety, hypothyroidism. Hyporeflexia can occur in hypotonia, sleep, anesthesia, and it may be lost if the lesion is affecting the reflex arc. Any part in the reflex arc, either in the efferent pathway, or in the center in the anterior horn cell, can cause loss of the tendon reflex, and the complete transection of the spinal cord. In the stage of shock, there is loss of all tendon jerks below this level. The cerebellum. The cerebellum can be divided into two hemispheres and verms. It has numerous folds called folia. Each cerebellar hemisphere is divided into three loops by two deep fissures, the primary fissure and the posterolateral fissure. This is the primary fissure and this is the posterolateral fissure. Into anterior loop, posterior loop, and the folliculonodular loop. But functionally, cerebellum can be divided into another classification, archicerebellum or the vestibular cerebellum, which occupies the folliculonodular loop connected with the non-auditory labyrinth to control the equilibrium, and any lesion here can cause loss of the whole body equilibrium, nystagmus, swaying when standing, unsteady when standing, staggering when walking, with tendency to fall backward. The paliocerebellum or the spinal cerebellum, formed of the anterior loop, the vermis, and the adjacent medial parts of the hemisphere, the paravermal zone. So the anterior loop, vermis, and the paravermis zone. It is connected to the spinal cord, controlling the axial muscles and the proximal limb muscles. This is controlled by the vermal zone, while the paravermal zone controls the distal limb muscles of the hands and the lower limbs. Its function is inhibition of the muscle tone, helping in coordination of the involuntary movement initiated by the extrapyramidal tract, and the lesion here will cause disturbance of the involuntary movement. The new cerebellum or the cerebellar cerebellum. It is connected with the motor area 4 and it occupies the lateral part of the posterior loop, helping in regulation and coordination of the voluntary movement and facilitatory to the muscle tone. The lesion here will cause hypotonia, asthenia, and motor ataxia. The function of the cerebellum or the mechanism of cerebellum in regulating and coordinating the voluntary movement is that the neocerebellum regulate and coordinate the voluntary movement by comparing the motor information coming from the motor area in the cerebral cortex with the sensory information coming from the contracting muscles. Neocerebellum is the part that connected to the motor area of the brain. So it compares the order coming from the motor areas and the sensory information coming from the contracting muscles, okay, by the following mechanism. The braking function. If the movement is too fast, it sends braking impulse to the motor cortex to stop the movement, so the contracting muscle and to inhibit the contracting muscle and stimulate the antagonist muscle and stop the movement or stop the limb exactly at the intended point. The damping function. Damping is stopping, so stopping the oscillatory movement caused by the momentum at the end of the movement. Predictive function. It also can detect the nature and the speed of the movement by the spinocerebellar tract, so it can predict the next position of the limb at any time during movement, so help in producing the proper muscle contraction. The lesion in the cerebellum can cause cerebellar ataxia or motor ataxia, which is characterized by clumsy movement. The patient is unable to do delicate movements like typing, like playing piano. Dysmetria. The patient is unable to judge the distance and force of the movement, resulting into either a stopping of the movement beyond the object, which is the hypermetria, or before the object, which is the hypometria. Decomposition of the movement. The patient is unable to perform complex movement in one step. Diadochokinesia or dysdiadochokinesia. The patient is unable to do rapid, successive opposite movement. Rebound movement. The patient cannot stop the movement in the proper time. Kinetic tremors, Rhythmic involuntary movements appear during movement and disappear during rest and sleep. The gait. The patient walks in a zigzag line and deviates toward the diseased side, then correct himself back to the original line and then deviate again, and so on. Speech, scanning or staccato speech. Each component in a word is pronounced separately and slowly. If it is a complete word by itself, it is an explosive, interrupted speech. Nystagmus, repeated rhythmic movement of both eyes when the patient looks towards the affected side. It is an example for the kinetic tremors of the eye. The basal ganglia. The basal ganglia include the caudate, globus pallidus, and putamen, or the lentiform nucleus, the amygdaloid body, mid nucleus, subthalamic nucleus, and the substantia nigra. The basal ganglia has several connections either with each other and with other centers in the brain, as there are numerous free interconnections among the various nuclei that forming the basal ganglia, and the corpus striatum is the receiving center of the basal ganglia as it receives afferent fibers from the cortex and the thalamus, and the functionally related nuclei like subthalamic nucleus, mid-nucleus, and substantia nigra, and the efferent or the discharge is through the globus pallidus. And also the globus pallidus is the discharge center of the basal ganglia, discharging to the cerebral cortex, to the thalamus, and other nuclei like the nucleus substantia nigra to the reticular formation. And it share in the cortical inhibitory circuits, which is the cortico-striato-pallido-thalamo-cortical circuit. Circuit starting in the cortex at area 4, supplementary motor area, to the corpus striatum, then globus pallidus, then to the thalamus, then again to the cortex to motor area 4 and 6. And the role of this circuit is to inhibit the overactivity of the cortical motor areas, area 4 and 6. So the disorders of the basal ganglia include the chorea, which is caused by caudate nucleus lesion. Chorea is involuntary dancing movement that occur during rest, increasing with emotion and disappear with sleep, and it is associated with hypotonia and pendular knee jerk as the caudate nucleus increase the muscle tone. Acytosis. The lesion is in the corpus striatum and the outer part of the globus pallidus, causing involuntary spasmodic slow twisting movement, snake-like movement in the upper arms, and associated with hypertonia. The hemiplegismus caused by subthalamic nucleus lesion, causing involuntary violent spasmodic movement that affect large area in the opposite side of the body, and the movements are so intense that they may cause the patient to fall down if he was standing or walking, and also it is associated with hypertonia. All of these problems and diseases will be discussed in details later, okay? The most common syndrome or disease affecting the basal ganglia is the Parkinsonism due to damage in the substantia nigra and manifested by muscle rigidity or hypertonia in all muscles of the body, more evident in the proximal muscles and the flexor more than extensor, and the patient is bent forward and takes the flexion attitude. Also, the voluntary movement are very difficult, slow, weak. So the syndrome is called paralysis agitans due to muscle rigidity. The patient sits like a statue because of the rare movement. Loss of associated involuntary movement, like swinging movement of the upper limb during walking. Also, loss of the facial expression during emotion expressionless face or mask face due to loss of the facial expressions. The speech is slow, monotonous, and of a low volume. The gait, short steppage and shuffling gait. Tremors. Tremors here is static tremors, involuntary rhythmic movement during rest and disappear during movement and sleep. It is more marked in the hand, the forearm, because it is less affected by rigidity. And thank you for your listening.